The reason why we're having this discussion is obvious. Supplement use is high in all phases of cancer care. Beginning with high-risk people who don't yet have cancer, there's found that 53 women in a high-risk genetic testing program for breast cancer were using complementary alternative therapies, including specifically dietary supplements here. And for most patients, use will increase dramatically after diagnosis. If you weren't a user before, most people become converted. It's sort of like a bedside conversion to religion. Hospitalized cancer patients, even in this condition where you're in the most acute kind of care, the supermajority of these patients have used complementary alternative therapies in the previous 30 days. Even during phase 1 trials when most of this is specifically excluded, use is still high. During radiation therapy, high use. And in certain kinds of cancer or certain stages of cancer, the actual use may exceed 90%. So I think as you approach a patient with cancer, the presumption should be that use is either imminent or actual. And if the patient themselves has not sought out different kinds of therapies, I think it's very fair to say that their family and friends who love them and are frightened for them have been recommending lots of different things for them. But I think there's a problem when patients and physicians, naturopathic physicians less so, but certainly conventional medical doctors, sit down to discuss joint use and a shared care model. Patients fear a negative response from their physician, and they're incredibly dependent on this physician, so they're very hesitant to frighten to get the doctor upset. And they actually have a good reason for that, because most physicians, conventional physicians, are very negative about CAM, especially if it takes the place of conventional therapy. Both parties believe that CAM can decrease side effects, and that's a good shared goal that we can work with. Patients, however, strongly feel that CAM should be useful to boost immunity. Physicians are less sure about that. Patients don't make their decision based on our scientific model of evidence. The most convincing recommendation for a patient is usually an anecdotal story of a good response or recommendation from a loved one or a trusted information source. So as OSHA told you, if you're going to interact with patients, you need to keep their lay medical advisors in mind. But given the fact that both parties have a different view of what evidence looks like, a study done at the Mayo Clinic actually showed that when looking at internet information, both physicians and their patients often had trouble distinguishing high-quality, bias-free information from low-quality information. So education is needed on both sides of this equation. Lisa, why don't you show us the model?
So the most common model for people seeking care who are diagnosed with cancer is this. The patient and always their family seek care. They are seeking care, obviously, from a conventional oncologist. And what we know is that, as Mary just illustrated, most patients are also seeking care from complementary and alternative medicine providers. Bad term, but we'll use it for now. And unfortunately, in seeking care from both of those provider groups, they're not talking to each other. So this is a perfect example of triangulated health care, which does no good for the patient and really is not serving the providers either. Another alternative way that things could be is to put the patient and the family at the center of the care model and to surround the patient and the family with, of course, all of the branches of conventional oncology when necessary and important, and then intersperse those with various types of complementary care. I've just listed some here. There are obviously many more. And to make sure that all those modalities are actually working together, again, for the good of the patient. This is not a triangulated model. This is a patient-centered or a patient-empowered model, and actually requires something very important on the part of all providers, and that is that they check their ego at the door.
Okay. So I want to spend a little bit more time thinking about disclosure of CAM use. Many of you, when you go back to your conventional centers and try to initiate this discussion, you may be met with the, my patients aren't doing this, so I don't need to know. And so I think we should think a little bit more about disclosure so that so that you have some evidence-based ways to answer that assertion. So non-disclosure is common. It can exceed, again, 90%. And this is especially true in the case where a patient fears to lose their conventional treatment if they disclose the use of an alternative or complementary therapy. However, they actually believe strongly in the complementary alternative therapy. So in that case, the patient withholds information from their providers, which I think we can all agree is probably a bad situation. But even in the best situation, about a quarter of patients are still not disclosing. Disclosure, even if it's done, is often not complete. And patients can, even in active therapy, disclose only about 57% of what they were using and were unlikely to disclose all their supplements. And I've seen this even in my practice where I'm the person on top of the door that it says I'm interested. I'll see patients do a series of testing behaviors. They'll first put out the thing that's the least alternative, and if I don't have a fit or know what it is, then they go further and further until they finally take something out of the bottom of the bag. So you need to make room for this disclosure to occur in stages and be very encouraging. And if this dietary supplement use is part of routine care, there's a VA head and neck clinic that routinely, the physicians often talk about supplements, they sometimes get their supplements from the VA, and disclosure is better there, and the physician is actively involved in the discussion. It goes into the hospital chart, which I think we can all agree would really improve, would even improve therapy even more. And you can see here, this is just a quick look at a bunch of different studies showing CAM use is often much higher than expected. This is an old slide from Marianne Richardson, but that disclosure is quite high and rarely goes above, often is above 50% and rarely is very low. So what kind of goals do we think are good for patients and their providers to agree on?
So this is sort of why do we even bother, and I think we've already touched on some of this morning, but essentially there are several goals for CAM therapies in the context of oncology. One clearly is to improve, sometimes just maintain, but more often than not improve the patient's nutritional status so that they can fare better with their disease and with the treatments that they're receiving. Also very important to try to manage side effects of treatment. I think in many ways this is the most convincing application of CAM therapies for a patient that's new to CAM because the benefit is so readily apparent to them. There are also increasingly studies which are indicating supplements can be used very specifically and selectively to improve the benefit of the conventional therapies that are used. Some CAM therapies are also helpful in preventing or reversing multi-drug resistance, the bane of medical oncologists. And supplements and other CAM therapies can be used to support immune function, which, as Mary spoke about, is very important to patients, a little bit less important perhaps to some of us providers, but still certainly has a role to play, particularly in the recovery stages. And clearly, CAM therapies can speed healing and recovery time during and after conventional therapies. There's a lot of symptom control that can be provided through CAM therapies. And just the very act of seeking alternative or supplementary therapies on the part of the patient does a lot to empower them and to give them a sense of hope and really renew their vigor.